Hello and welcome. My name is Dr. Rizwan Qureshi, and today we're going to be talking about CNS infections. So, without further ado, let's jump right into a case. So, the first case involves a patient who is a 62-year-old patient by the name of Ronald Smith, who presents with a headache for 3 days. He's also been complaining of photophobia, some neck stiffness, and fevers. You already know where this case is leading. The headaches are worsening, and he's now complaining of some vomiting and some blurred vision. He's gone to the GP who's asked him to come to emergency department. He's got a background history of migraine, depression, and some anxiety. He's got normal blood pressure, normal pulse, but he is febrile to 38 degrees Celsius. His saturation and blood sugar are normal. So, before you even think about anything else, what are the key differentials which are going through your mind? Now, in terms of remembering the key differentials, remember the mnemonic vitamin. So V stands for vascular. So the differential in this case could be subarachnoid hemorrhage or intracerebral hemorrhage. It could be infection, obviously, given the fact that he's got a fever. So like cerebral abscess, meningitis, encephalitis. And the meningitis could be either bacterial or viral. What about trauma? Now, there is no history of trauma, but the trauma could have happened a few days ago. So always inquire about any recent trauma. Autoimmune, like temporal arthritis, which can cause jaw claudication and pain specifically over the scalp while brushing the hair and so forth. Iatrogenic, some sort of surgery, ENT, eye, or any neurosurgical procedure could be the cause of this headache too. Endocrine, neoplastic. It could be a primary or a secondary brain cancer. So think of all these differentials, and that will help you narrow down your working diagnosis. Now, before you go and start talking to the patient is suffering from severe headache. He is having vomiting. So I want you to remember the mnemonic MOPS. M for morphine, O for ondansetron, which is an antiemetic, and P for paracetamol, which is a simple standard analgesia. Now, I like these medications because you can give them through multiple routes. Morphine can be given both oral in a form of an endone, IV, IM. Ondansetron can be given in a form of wafer if you've not gotten cannula or IV. And Panadol can be given oral, IV, and even rectally. So once you've got a patient who is comfortable, he looks a little bit like that. So a lot happy. So where do they see this patient? So you're already suspecting the patient has got some sort of cerebral central nervous system infection. So you'd like to see him in an area which is a bit more close and monitored because he could rapidly deteriorate, he could have a seizure, so acute monitored bed. And obviously, if you're suspecting meningitis, you need to have him in a close, isolated room with droplet precautions. In terms of the history, you need to ask all the components of the history. So the patient tells you that he's been unwell for the last 3 days. The headaches pretty different from his usual migraine. Migraine tend to affect him on his right side of the head, associated from some aura. These are generalized throbbing headache radiating on the back of the neck, which are causing him to have a very stiff neck. He's also been suffering from some blurred vision, and also he's been having some balance issues. So they are quite different from his usual migraine headache. Now, in the last 24 hours, he's also been having fever and vomiting, so he's not been able to keep anything down. You need to ask him about the past medical and surgical history. And luckily for this patient, he's only got a history of migraine, but nothing surgical. He's got a history of depression for which he's on Zoloft. And allergy wise, he's got no allergies. He works as an accountant who is only working part time. He does not smoke, does not drink any alcohol, or denies any recreational medications. Now, in terms of examination, always repeat a set of vitals, which are pretty much the same, but the fever 38.5. What about the CNS infection? I'll give you the pinpoint sign. He's got restricted net movements. He's got a positive Koenig sign, and his sinus taps, which may suggest that he has got an alternate sinus infection, is negative. The rest of the examination in terms of cardiovascular, respiratory, abdominal, and skin examinations are all normal. So the working diagnosis obviously is either a viral or bacterial meningitis. The differentials would be encephalitis, brain abscess, sinusitis. Obviously, the facial pains and headaches could be from sinuses, or a pneumonia. Yes, streptococcal pneumonia can cause a very bad headaches. Go check out the textbooks. Now, treating the suspected bacterial meningitis. Now, you've not done any tests right now, but you're suspecting that he has got either a bacterial or a viral meningitis. You need to treat him. The first thing that you'd give him is a third generation cephalosporin, which would be either a ceftriaxone and dexamethasone, which prevents the complication in terms of brain swelling and cranial nerve palsies. So that is even before touching the patient, or if you're not going to do the LP immediately, which means within sort of 30 minutes mark. Now, what about doing an LP before the CT brain? There was a study which I found, which was done by the Infectious Diseases Society of America, and they said that delaying the LP for obtaining a CT brain increase cost, and it's not really advisable. Usefulness of head CT in patients with community acquired meningitis without an indication for an imaging is limited and has no impact on clinical management, meaning that you don't have to do a CT of the brain for every suspected meningitis patient who are well looking, who are GCS 15, have got no focal neurologic deficit. And there are some other sets of uh, criteria which I'll go through in detail. But basically, if the patient is well, as this patient, you don't have to delay the LP for the CT. Now, what test? The bedside test, we did the VBG. The lactate is up. Normal range is about 2. His is 3.2. His glucose is 8. His urine's normal. These are the bedside tests. His laboratory tests show a white cell count of 18, hemoglobin of 134. White cell count obviously is elevated, predominantly neutrophils of 9.5, and his platelets normal 320. And then this is how his ECG looks like, which shows mild sinus tachycardia. He's also got a CT brain done. I don't know why, but it happened, which looks normal. His chest X-ray also looks normal. Moving on. So now you're planning to do a lumbar puncture. So lumbar puncture is a procedure which involves obviously putting in a spinal tap needle in the back between the L3 and L4 space, and you need to take a sample of the CSF and send it to the lab immediately for the culture and diagnostics. It is an invasive procedure. I always consent my patients. What equipment you require? You require a lumbar puncture set. You need a set of lumbar puncture needles, which could be Quincke needle, Whittaker needle, and Sprout needle. Quincke needles are cutting needles that are easy to pass through, and but there is a risk in terms of they cause large dural punctures and can cause an ongoing CSF leak and hence post LP headache. In order to offset that side effect, the Whittaker and Sprout needles are used, but they are very malleable. If the patient is particularly strong built and has got a thick back with a lot of subcutaneous fat and skin, then these needles require a fair bit of skill to pass in through. So just a bit of an introduction from the needles perspective. Next up, must use lignocaine. I also pre-medicate the patients with midazolam and fentanyl because obviously this is a very painful procedure, and giving a fentanyl and midazolam will help eliminate a lot of pain and anxiety from this procedure and virtually have a little bit of procedural sedation from that point of view. Now, we've got the CSF results back. His opening pressure is 32, which is high. The appearance, as you can see, looks turbid. He's got a white cell count of 100, which is quite elevated. He's got a protein of 40. He's got a glucose of 2, which is low. He's got a gram stain, which is positive for cocci. His xanthochromia, which is a sign which we test for subarachnoid hemorrhage, is negative. So if you look at the ski which I've produced, he's got all the parameters within the bacterial line. His ICP is up, turbid appearing. He's got a protein which is up, glucose which is low, and it's got a very high white cell count. So patient confirms to have a bacterial meningitis. What if the CSF results would look like something like that? His opening pressure being 19, clear and colorless, which it looks like. He's got predominantly lymphocyte-based white cell count. He's got gram stain, which is negative, protein, which is less than 20, so normal to decreased. And he's got a glucose, which is normal range 6, and he's got a xanthochromia, which is negative. So it is more in keeping with the viral meningitis. So a specific management, moving the patient to the isolated room and admit neurology. Obviously, we've already done those things before. The patient has already been giving dexamethasone 10 milligrams stat IV and third generation cephalosporin, ceftriaxone 2 grams stat. Obviously, always check your ETG guidelines and check for patient allergies before giving any medications. You need to add on benzyl penicillin if you're worried about listeria, and add on vancomycin, especially if they've got gram-positive diplococci. And if you're suspecting that the patient may have viral meningitis, you need to add on cyclovir for HSV and ganciclovir for CMV. All right, moving on. What would be the journal management? Obviously, the patient did not come here just for diagnosis. He came in for his symptom relief as well. So have him on regular analgesia, regular paracetamol, breakthrough endone or morphine or fentanyl for stronger pain relief. He needs to have a regular antiemetic. He needs to also be well hydrated during this time, recuperating from illness. So normal saline over 6 hours bag, titrate to his urine output, blood pressure, pulse. Normally allowing diet early if they can tolerate would be good. So as soon as possible, diet can be allowed. He needs to have a 4-hourly neuro-ops, especially if he is showing signs of improvement, but more quickly so if he has got signs of raised ICP, like an ongoing thropic headache. He's got signs which show like a little bit of papilledema. He's got signs which show that he has had like he's had symptoms of seizures. Then you need to reduce these to hourly neuro-ops, once obviously controlling those emergencies. And he's been admitted in neurology. In terms of handover, you need to identify yourself. That my name is Dr. Rizwan Qureshi. I'm actually referring you about a patient who's a 62-year-old chap who's in emergency department with suspected meningitis. You need to present the situation that I've got a patient with a suspected meningitis based on the fact that he has got um, headaches for the last 3 days, generalized headache, associated fever, neck stiffness, and vomiting. Then give only your positive findings. And in terms of my clinical examination, he's febrile, he's hemodynamically stable, but has got positive Koenig signs and has got features of neck stiffness. So everything is adding to the value of your history narration that this patient is strongly um, suggests that he's got meningitis. So what would your recommendation be? Obviously, he needs to be isolated and admitted for an ongoing treatment with antibiotic therapy, steroid therapy. He also needs to be monitored from the point of view of any deterioration in terms of sepsis. His lactate was up, which could be an early surrogate marker for a septic shock. So it needs to be watchfully, he needs to be closely observed from that point of view. And he needs to have obviously the chasing of the cultures of CSF that you've just sent. So let's just talk about what could be the most common bacteria which cause meningitis. So the most common bacteria are three: Streptococcus pneumoniae, H. influenza, and Neisseria meningitis. And where do they come from? They come from upper respiratory tract infection, so ear, nose, and throat. They come for ear infection. This is an example of a bulging middle ear, bulging tympanic membrane with a pus behind the tympanic membrane on one aspect. They also come from sinus infection. This is left maxillary sinus, which is looking all opacified. If you look at this, the right maxillary sinus on this side obviously shows that he has got a partially opacified pus-filled cavity here, but a lot more air here, which looks black. And obviously they come from distant source. So the infection might be going somewhere else. It might be going on in the legs in terms of cellulitis. It might be going somewhere else in the heart in terms of endocarditis, and they may have a hematogenous spread. What would be the clinical features? The most common clinical features are obviously fever, headache, and neck stiffness. But obviously, if you are suspecting the patient's got an altered mental state, either they've progressed very far in their meningitis, or they may have an underlying encephalitis, especially HSV. The patient may have an isolated feature of facial nerve paralysis or facial asymmetry. They may have eye coordinated movements compromised because of third, fourth, and sixth cranial nerve palsies. They may have focal deficit. They may have homonymous hemianopia. So these are all very pertinent signs. What about the meningeal irritation? What is it meant by the signs of meningitis? So meninges is the layer which covers the brain and the spinal cord. It's organized in dura, subarachnoid layer, and a pia mater. Obviously, it becomes inflamed in the process of meningoencephalitis. So any stretching of this meningeal layers causes a lot of pain and discomfort to the patient. So signs of meningeal irritation: any sort of passive stretch to the patient's neck, on forced neck flexion, which will cause a lot of pain to the patient's neck. What about Brudzinski signs? So remember, when doing the Brudzinski sign, you're still trying to passively stretch the neck, and the patient will, flex his hips and flex his knee. And I'll show you a picture of that. And Koenig signs is when you're trying to, the Koenig signs, which shows here the patient's got a flex hip and he's got a flex knee, but when you're trying to extend the knee in order to stretch the meninges, he'll have a reflex contraction of hamstrings there. And Brudzinski sign, as I suggest, that you're trying to lift the neck up from the bed, and the patient will immediately cause a flexion of the hip and the flexion of the knee. So these are the signs of the meningeal irritation, which are strongly suggestive of meningitis. Now, what about when to do the brain? What would be the indication of bringing the brain CT before an LP? So the patient who are elderly, suspecting that they may have an underlying mitotic lesion, neoplastic lesion, primary or secondary cancers. They may have focal neurologic deficit. They may have seizures. They may be immunocompromised, may have had previous history of tumors or strokes. This is how the swollen brain looks like compared to a normal scan. What would be the other test that you can do to pick them up, it could be associated with papilledema. So this is like a papillodemus disc in which you can see the fundus is all blurred, but in this normal area, the fundus look quite sharp. And finally, you may have a patient with space occupying lesion. This appears to be a large cyst, which might be causing increase in the intracranial pressure, and that might be causing a discomfort. All right, moving on. So we are suspecting the patient has got suspected community-acquired meningitis. So these are the therapeutic guidelines. So if you're suspecting patient to have bacterial meningitis and they're immunocompromised, they've got a history of CNS disease, and they've had new onset of seizure, papilledema, altered level of consciousness, or focal neurologic deficit, what you need to do is think whether they belong to this group. If they do, then you need to do blood cultures only. All right. And you don't need to do anything else. If they don't, then you need to do blood cultures and lumbar puncture. That means the patient's only got headache, neck stiffness, and fevers. Then you need to do blood cultures and lumbar puncture stat. What is the next step? You also need to give them dexamethasone and empirical third generation antibiotics, suspecting any of the bacterial sources in terms of strep pneumoniae, meningitis, and H. influenzae. And obviously, in that other group, you need to give them dexamethasone and empirical antibiotic therapy as well. If the CSF findings are consistent with bacterial meningitis, yes, then you need to continue off with this treatment. So positive CSF gram stain, yes, then you need to continue on with dexamethasone and antimicrobial therapy. If the CSF findings are not consistent with bacterial meningitis, then you need to really think about where the infection is coming from. Why is febrile? Why is got raised inflammatory markers? And what's happening in there? But in that case, you need to look very hard because the patient may have other life-threatening infection. Looking on to the other side, in which we decided not to do the CT of the head because the patient had focal neurologic deficit, had seizures. But after the empirical antibiotic therapy and the patient stabilized, you can still perform the head of the CT head because he may have a bleeding, he may have something else which needs to be under, he may have cerebral abscess. So contraindication for lumbar puncture, which we have discussed briefly in the previous slide. Then if there are contraindications, then you need to continue on with the antibiotic therapy alone, dexamethasone, and that would hopefully treat the infection. But if there are no contraindication or ongoing contraindication to the lumbar puncture, then you need to perform the lumbar puncture, even though at a later date. Moving on. What about the sinus meningitis? So sinuses are those air-filled cavities which are maxillary sinuses, sphenoid and ethmoidal sinuses, and they are normally reasonable. They're the air pockets which are responsible for giving the resonance to our sound, and they're very important for us in terms of communicating. They also filter the air. They can be filled up with mucus and can harbor many bacteria, which can give rise to meningitis. So sinusitis, meningitis account for 10%. They're mostly polymicrobial, and the treatment of antibiotics are metronidazole in addition to third generation cephalosporins. And obviously you need to refer them to ENT surgeon because look at this left maxillary sinus, which is completely opacified. All this gray material, that's opacification of the left maxillary sinus with the pus or mucus and back and forth, another thing. On the right side, the maxillary sinus got some aeration. This is looking like a normal air-filled sinus, but has got an early buildup of the mucus or pus cavity there. Moving on, what about the meningitis complication? Obviously, most of the complications are from raised ICP, vasculopathy, and seizures causing brain ischemia. And most of the guidelines would suggest using mannitol, but obviously refer to your own local area health network guidelines, discuss with the senior, discuss with the ICU specialist if the patient is showing signs of raised ICP, which would be clinically having seizures or having reduced level of consciousness or altered level of consciousness, papilledema, or radiologic features suggestive of seizures. In that case, you must give patients mannitol. What about viral meningitis? Now, majority of cases are actually viral meningitis. 85% or so are viral meningitis. Most common viral meningitis, in fact, majority of 85% cases of the meningitis are viral. These are the common viruses like echovirus, coccidiovirus, and enterovirus. The other viruses which can cause infection are CMV, HSV, HIV, and adenovirus. And one thing to remember is that an early bacterial meningitis or partially treated bacterial meningitis could be very similar to viral meningitis. Moving on, the most of the protocols do recommend covering the patient for both the meningitis for bacteria and for virus at the same time, because you don't know that for sure, because the early phase of the illness, they can look very similar. Moving on, what about the viral encephalitis? Especially, it coexists with viral meningitis, especially if the patient's got no psychiatric symptoms, very agitated, very confused, or hallucinating, needs to be controlled down, then the strongly suggest viral encephalitis. In fact, in practice, when the patients who are not known to be mental health patients and have come in very acutely agitated and there's no explanation, they've got fever, then we must do an LP. And we've actually identified quite a few patients in this kind of mindset who have got an underlying encephalitis. Moving on, the patients who have got cognitive deficit and aphasia and amnesia also are the patients suspected of viral encephalitis, seizures, and movement problems. MRI is more sensitive and specific for the diagnosis of viral encephalitis. It may be completely normal early in the disease, but then it may show some patchy changes, which might be small focal hemorrhages. It might be some edema in the area with the viral infections ongoing and inflammation, and so forth. The treatment for viral meningitis is cyclovir, especially if it's herpes simplex virus, or ganciclovir if it's cytomegalovirus. What about brain abscesses? So brain abscesses are mostly from hematogen spread. They come from middle ear, sinuses, and also dental infections. And if the patients have had some sort of neurosurgical procedure, opening up the dura, and they've obviously been exposed to the outside bacteria, they can also have brain abscesses. Again, ear infections can cause brain abscesses as well. What would be the clinical signs? They may have, again, papilledema. They may also have homonymous homeonopia or visual field defects. And obviously, this is how the CT scan of brain abscess looks like. There's a ring enhancing lesion onto the right-sided parieto-temporal lobe of this patient. Also, always remember the brain abscesses are focal pyogenic cavities, which are pus-filled cavities. And if the patients are immunocompromised, think of TB and toxoplasmosis. How are they treated? Mostly with an operation. Initially, we obviously give them antibiotics in consultation with infectious diseases. They are polymicrobial, coming on from various different sources in the body because the hematogen spread. So we need an early expert input from an ID. They need surgical drainage. This is a procedure in which they open up depending on the size of the brain abscess, and then the abscess has been drained. And this is the CT scan suggested. I remember when I was working as an intern, one of the first house job that I was doing was in neurosurgery, and the resident actually took me through one of the brain's abscesses drainage, which was very early in my career. I got exposed to a very remarkable procedure, and the patient did very well. So something to consider. So key take-home points for this conversation and tutorial would be, in terms of CNS infection, suspect and treat with empirical antibiotics and dexamethasone as soon as you've got a differential or working diagnosis of either bacterial or viral meningitis. You don't delay for the LP for well patients. If the patient's a GCS 15, if they're talking well, if they've got no focal neurologic deficit, you don't have to delay the LP. You just do the LP and forget about the CT brain. Obviously, do the CT brain if they've got any of the indications that we've talked about. And finally, if the patient's psychotic, agitated, requiring a lot of security to calm him down and pinning him down to the bed, then suspect that they might be encephalitic. Thank you very much. I'll do some more lectures and come back to you again. Thank you very much. Look after yourself. Bye.